We're going to discuss the examination of the motor system under the following headings. We're going to assess the bulk of the muscles, the tone of the upper limbs and the lower limbs, followed by assessing the power of the muscle groups in both the upper limbs and the lower limbs. There will also be assessment of the reflexes and the coordination. In the sensory examination, we're going to assess the lateral spinothalamic tracts and the dorsal column pathways. More specifically, we're going to assess the sensations of pain and temperature, and we're going to assess how we're going to examine joint sense, vibration sense. Lastly, we're going to assess the gait of the patient. Coming to the examination of the motor system. The examination of the motor system begins with inspection of the limbs. Look for any wasting or any hypertrophy of the muscles. If in doubt, measure the circumference of the limb above a fixed bony point, above and below the joint. Please look for any muscle fasciculations. Muscle fasciculations refer to irregular contraction of the muscle fascicles, and this may be brought about by gently tapping the muscles. After inspection, look for tone. What is tone? Tone is defined as the resistance offered by a normal muscle to passive movement. If the tone is increased, it is called hypertonia. And if the tone is reduced, it is called hypotonia or flaccidity. Tone is regulated by the corticospinal tract and the extrapyramidal tracts. If there is a lesion in the corticospinal tracts, the type of hypotonia is called spasticity, or specifically clasp knife spasticity, wherein there is an increase in resistance at the beginning and the end of passive movement. On the other hand, a lesion in the extrapyramidal tract gives rise to rigidity, which may be either cogwheel type or lead pipe rigidity, wherein the resistance offered by the muscle is uniform through the range of movement. In cogwheel rigidity, there is a jerky movement during the entire range of movement while you extend or flex the muscle. Before assessing the tone in a patient, make sure that the patient is relaxed. In the upper limb, tone is checked by flexing and extending the wrist and the elbows. In the lower limbs, tone is assessed in multiple ways. The first way is to flex or extend the knee while palpating the muscle that you are checking. The second way is to roll the limb over the bed surface. And the third way is quickly lifting up the thigh and looking at the movement of the leg. In patients who have hypertonia, the leg is going to kick upward, whereas in hypotonia or flaccidity, the leg is going to drag when you quickly lift the thigh up. Now we're going to see how to demonstrate tone in a patient. Hello, I'm going to be moving your hands and legs. Please stay relaxed, and this is not going to hurt you, all right? Can I see your hands? So to check the tone of the upper limbs, I'm going to be flexing and extending the wrist, at the same time feeling the resistance offered by the muscles. In the upper limb, please notice the resistance offered by the biceps and the triceps while flexing and extending the elbow. Compare it with the other limb. Same goes for assessment of tone in the lower limbs. Please lie down. One way of assessing the tone in the lower limbs is flexing the knee and extending the knee. Another way to assess tone is by rolling the leg gently on the bed surface. While doing this movement, please note for the floppy nature of the foot, which will be much more elaborate in patients who have hypotonia. The third way to check tone is quickly lifting the thigh and looking at the response of the leg. In a patient with spasticity, the entire leg is going to kick upward, whereas in hypotonia, the leg or the heel will drag on the surface of the bed. This is how we demonstrate tone in the lower limbs. The next aspect of examination of the motor system is assessing for muscle power. The muscle power can be assessed according to grades that are set out by the Medical Research Council scale. Grade 0 power refers to when the muscle has no power, there is no movement noted. In grade 1 power, there is a slight flicker of movement noticed in the muscle. Grade 2 power refers to when the patient can move his muscle against eliminating gravity. In grade 3 power, the patient can move his muscle against gravity. Grade 4 power refers to when the patient can move against gravity and against minimal resistance. And grade 5 power is normal power. If you suspect a lesion in the pyramidal or the corticospinal tract, there is an easy way to look for any weakness of a particular group of muscles. Ask the patient to stretch his arms out with his palms supinated. If there is weakness in any part of the body, the arm will slowly drift down and the hands will slowly pronate. This is also called a pronator drift. However, if you suspect a lesion at the level of the nerve root or the nerve, you have to assess the individual muscle groups. Now we're going to assess individual muscle groups of the upper limb and the lower limb. This is how we're going to look for a pronator drift. Can you stretch out your hands with your palms facing upward and close your eyes? As you can see, there is no drifting of the arm and the palms face upward. Thank you. In a patient with a pyramidal tract lesion, there is going to be drifting of the arm with pronating of the palms. Coming to the examination of the muscles of the upper limb. The serratus anterior is tested by asking the patient to push against a wall. In a patient who's got a weak serratus anterior, there will be winging of the scapula, which means the medial border of the scapula will become more prominent. Shoulder abduction tests the deltoid muscle. This is tested by asking the patient to abduct his arms against resistance. Can you lift up your arms? Okay. Elbow flexion tests the biceps muscles. We are going to ask the patient to flex the elbow against resistance. Can you flex your elbow? Okay. Elbow extension tests the triceps muscle. This is done by asking the patient to push his hands against resistance. Can you hold your hand? Can you push your hand against mine? Examination of the brachioradialis is done by asking the patient to flex his elbow with his hand kept in a mid-pronated position. Can you keep your hands like this? Can you push my hands up now? Coming to the examination of the fingers. Can you keep your fingers straight? I'm going to push them down. You're going to push my fingers up. Can you push it down, up? By doing this, we are checking the extensor digitorum muscles. Now to check for thumb extension, I'm going to ask the patient to extend his thumb against resistance. Can you keep your hands out? Can you push my thumb out? By this, we check the extensor pollicis brevis and longus. Now to check for finger flexors, I'm going to ask the patient to flex his fingers while the examiner tries to pull it out. Can you keep your fingers folded? Can you keep it folded? This is checking the flexor digitorum profundus. The first and second flexor digitorum profundus are supplied by the median nerve, whereas the third and the fourth flexor digitorum profundus are supplied by the ulnar nerve. The opponent's pollicis is tested by asking the patient to touch the base of his fifth finger with his thumb, while the examiner tries to resist this motion. Can you try to touch the base of your fifth finger like this? This checks the opponent's pollicis. Finger abduction is tested by asking the patient to keep his fingers extended and spread out while the examiner tries to force them in. Can you please put your hands out and spread your fingers like this? This is testing the first dorsal interossei and the abductor digiti minimi of the little finger. Now coming to the examination of the muscles of the lower limb. Can you please lie down straight? Hip flexors are tested by asking the patient to flex his hip against resistance. Can you please fold your legs? Can you pull your legs to your stomach? This is testing the iliopsoas muscle. Hip extension is checked by asking the patient to push the examiner's hand against the bed. Can you push my hands with your legs? This is testing the hip extensors, which is the gluteus maximus muscle. The knee flexion is checked by asking to flex the patient's knee against resistance. Can you flex your knee? Can you push my hands down? Thank you. This is testing the knee flexors, which are the hamstring muscles. Knee extension is tested by asking the patient to extend the knee against resistance. Can you fold your leg again? Can you push my hands upward? This tests the quadricep muscles. The hip abductors are checked by asking the patient to abduct his leg against the examiner's resistance. Can you push my hands outward? The hip abductors are the gluteus medius and the minimus. The hip adductors are checked by asking the patient to keep his legs together against the examiner's resistance. Can you keep your legs inward? Now coming to the dorsiflexors of the leg. The dorsiflexion is tested by asking the patient to flex his foot against resistance. Can you lift your foot like this? I'm going to push it down, you're going to push it up. Okay? Can you do it? Dorsiflexion tests the power of the tibialis anterior. Plantar flexion is checked by asking the patient to push the examiner's hand against resistance. I'm going to push your foot up, you're going to push my hands down. Can you do that? Plantar flexion tests the gastrocnemius and the soleus muscles. Checking the extensor hallucis longus requires the patient to extend the patient's big toe against the examiner's resistance. You will have to pull up your big toe against my hand. Can you do that? Inversion of the foot is checked by asking the patient to invert the foot against resistance. Can you invert your foot? This checks the tibialis posterior muscle. Eversion can be checked by asking the patient to invert the foot against resistance. Can you invert your foot? This checks the peroneus longus and the brevis. Coming to the examination of the deep tendon reflexes. Reflexes are of two types, deep tendon reflexes and superficial reflexes. The deep tendon reflexes of the upper limb are the supinator reflex, the biceps reflex, and the triceps reflex. Whereas the deep tendon reflexes of the lower limbs include the knee jerk and the ankle jerk. The superficial reflexes that we are going to check include the abdominal reflexes, the cremaster reflexes, and the plantar reflex. First, we are going to start off by demonstrating the deep tendon reflexes. The supinator jerk is demonstrated by hitting the knee hammer against the distal end of the radius. What is noted is flexion of the elbow and slight flexion of the fingers. This is how we are going to demonstrate the supinator reflex. Can you keep your hands on your body? Just relax. Keeping your finger on the distal end of the radius, I am going to strike it with my knee hammer. This is compared with the opposite hand. The biceps jerk is tested by hitting the tendon of the biceps muscle with the knee hammer. The triceps jerk is tested by asking the patient to gently lift his hand, supporting the patient's hand. I am going to strike the tendon of the triceps muscle with my knee hammer. Just relax. Leave it in my hand. Leave your arm on my hand. Coming to the examination of the reflexes of the lower limbs. The knee jerk is tested by asking the patient to rest his knee on the examiner's hand while you strike the patellar tendon. I'm going to put my hand under your knee. Just relax. Just leave your leg loose. Just relax. The ankle jerk is tested by asking the patient to rotate his leg while slightly dorsiflexing the patient's foot. Can you just flex your leg? Just relax. If the deep tendon reflexes are not being elicitable, there is a way to elicit these. This is by doing a maneuver which is called the Gendra 6 maneuver. The patient is asked to clench his teeth or to pull his fingers against each other like this. This is the examination of the deep tendon reflexes. Now we are going to talk about how to examine the superficial reflexes. We are going to start off by examining the abdominal reflexes. The examiner is going to stroke the skin lightly over the abdomen, coming from outward to inward and looking for contraction of the abdominal muscles. This is checked in 4 quadrants. Can you lift your shirt up, please? Using a blunt object like a key, I'm going to stroke the abdomen of the patient, going from the outer quadrant to the inner quadrant. In a patient with a lower motor neuron lesion, the superficial reflexes will be lost. Another superficial reflex that can be demonstrated is the chromatic reflex, wherein the skin of the thigh is stroked gently upward to look for the contraction of the chromatic muscle. We will not be demonstrating this reflex. The last and the most important superficial reflex that we need to demonstrate is the plantar reflex. This is demonstrated by stroking the sole of the patient's foot on the lateral aspect and going up to the ball of the foot. A normal plantar reflex is flexion of the great toe with adduction of the remaining digits. In a patient with a corticospinal tract lesion or a pyramidal tract lesion, there will be extension of the great toe with the fanning of the other digits. Using a blunt object like a key, I am going to stroke the patient's sole starting from the lateral aspect of the foot. I'm going to be touching your foot with my key. It's not going to pain. As you saw, there was flexion of the great toe. There can be instances where this reflex may be absent. A positive plantar reflex is also called a Babinskis reflex. In extensive lesions of the corticospinal tract, there are other methods to demonstrate this plantar reflex or a Babinskis reflex. One such maneuver is called the Oppenheim sign, wherein deep pressure is applied on the medial border of the tibia. The second way to demonstrate is called Gordon's reflex, wherein gentle pressure on the calf muscles will elicit a positive Babinskis. And the third, called the Schaefer's sign, involves gentle pressure over the Achilles tendon. I'm now going to demonstrate each of these maneuvers. By putting gentle, deep pressure over the medial border of the tibia, this is called Oppenheim sign. pressing the calf muscles is called the Gordon's reflex, whereas pressing the tendon, Achilles tendon, is called the Schaefer's reflex. Remember, if there is an extensive corticospinal lesion, each of these is going to elicit a positive Babinskis reflex. The next aspect of testing the motor system is looking for coordination. Incoordination or ataxia is an important sign of cerebellar disease. We are going to be demonstrating looking for coordination in the upper limbs and the lower limbs. Can you please sit up? Can you touch the tip of your nose with your finger and then touch my finger here? Can you do this rapidly? Thank you. While performing this maneuver, please make sure you look for dysmetria or pass pointing. Also look for intention tremor, that is, tremor that is seen when the patient performs a movement. The next step is to look for dysdiadochokinesia. This is the inability of the patient to perform rapidly alternating movements. This is how we are going to demonstrate dysdiadochokinesia. I'm going to ask you to move your hands like this. Do it as rapidly as you can. Okay? Can you do it? Okay. Can you do it with the other hand? Okay, thank you. In a patient with cerebellar disease, these maneuvers will not be possible. This is called dysdiadochokinesia. Now, coming to the examination of the coordination of the lower limbs. Can you please lie down? The test that we are going to perform is called the knee heel test. This is done by asking the patient to take his heel from the knee of the other leg right down to the ankle. A patient who's got a cerebellar disease will not be able to perform a smooth movement. Can you lift your leg? Take your sole from here, from your knee, right down to your ankle in a straight way. Okay, can you do that? Okay, please do it. Can you do it with the other leg? As you can see, the patient is able to draw a straight line from his knee right to the ankle. In a patient with a cerebellar disease, this may not be possible. The next aspect of examination of the nervous system is testing sensations. This tests the integrity of the ascending pathways, namely the spinothalamic tracts and the dorsal columns. We are going to check pain and temperature to assess the integrity of the spinothalamic tract, whereas checking for vibration and proprioception or joint position sense checks the integrity of the dorsal column. Now coming to checking the sensations of pain, it is vital for you to explain to the patient that you're going to use a sterile pin and show to the patient that this is what a sharp or a painful sensation is going to feel like. Before you start off the examination of the sensory examination, you need to be aware of the dermatomes of the body. Now, I'm going to tell you an easy way to remember the dermatomes. The middle finger corresponds to the C8 dermatome. The nipple corresponds to the T5 dermatome. And the umbilicus corresponds to the T10 dermatome, while the inguinal ligament corresponds to the T12 dermatome. Now I'm going to demonstrate how we check for pain sensation. This is a sterile pin. Before I check the sensation for pain, I'm going to explain to the patient what the sensation is going to feel like and how I'm going to do it. This is a pin. I'm going to use this to touch your body. It's not, if you feel the sensation of pain, you have to count out loud. You will have to do this with your eyes closed. Is that okay? Let's do a demo, okay?
1, 2, 3, 4, 5.
Okay, shall we do that from the beginning? All right. Keep your eyes closed.
1, 2, 3, 4, 5, 6.
Likewise, we will do this maneuver in the lower limbs as well. I'm going to start again.
1, 2, 3, 4, 5, 6.
This maneuver is performed fast so that there is no confusion regarding the sensation of pain. Likewise, we are going to do this maneuver with a cold and a warm test tube to check the sensation of temperature. Now coming to the sensations which are carried by the dorsal column. These include vibration sense and proprioception or joint position sense. I am now going to demonstrate how proprioception is done. Can you please sit up? I am going to take the patient's finger and move the tip of the finger up and down. This has to be explained to the patient. Patient has to tell whether the finger is up or down with the patient's eyes closed. I'm going to be holding your fingertip and I'm going to move down, and up. You have to identify whether your finger is down or up, and this has to be done with your eyes closed. Is that okay?
Okay.
All right.
Down, 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 up.
Likewise, we're going to do the same for the lower limbs. Remember, if there is any abnormality in this proprioception sense, you have to use a proximal joint to perform the same. I'm going to do the same with your foot. This is down, this is up. Okay? Can you close your eyes?
Down, down, up, down.
Please don't forget to compare the limbs. Now we're going to assess for vibration sense. This is done by using a tuning fork of 128 Hz frequency. We start off with the most distal joints and progress upward if the patient is unable to feel the sensation of vibration. This is the tuning fork. I'm going to strike this and put it on your ankle. Can you feel the vibration?
Yes.
Okay. When you stop feeling the vibration, please let me know. Okay? Close your eyes.
Stop.
Okay.
Stop.
If the patient is unable to perceive the sensation of vibration, move to a more proximal joint and repeat the test again. If the above mentioned tests are normal and you suspect a cortical lesion, the following tests are useful, and these are called cortical sensations. The first cortical sensation that I'm going to check is called 2-point discrimination. This is the ability of a patient to perceive two blunt points as individual points. Normally, the patient can perceive two blunt points at a closer distance in the hand, whereas the distance widens as you test the leg. This is how I'm going to test for 2-point discrimination. I'm going to use these blunt points and touch your hand, and you have to tell me whether you perceive it as 1 point or 2 points. This you will have to do with your eyes closed. Okay? Can you put your hands out? Put them down.
Two points. 2 points. 1 point.
This is considered normal. The next cortical sensation that we're going to test is called sensory inattention or perceptual rivalry. In this, the patient is asked to put out his hands while the examiner touches one or both hands and asks the patient whether he can perceive it as one or both hands being touched. Can you put out your hands? I'm going to touch one or both of your hands and you have to tell me which hand I have touched. You will have to close your eyes.
Left hand. Left and right.
Good. Thank you. The next cortical sensation is called stereognosis. This involves or checks the ability of the patient to recognize objects when placed in the patient's hand. I'm going to place an object in your hand and you have to tell me what it is. This you have to do with your eyes closed. Can you put out your hand? Close your hand. What is this?
It's a coin.
Okay. Thank you. The next sensation is called Graphisthesia. This involves drawing numbers or alphabets on the patient's palm while the patient has kept his eyes closed, and the patient has to recognize what number or alphabet was drawn on the patient's palm. I'm going to draw a number on your hand. You will have to identify the number, and this has to be done with your eyes closed. Can you keep your eyes closed and put your hand out?
Number 3.
Okay.
Number 1.
Good. These are the cortical sensations that we have just checked. Coming to the last part of the examination, and that is assessment of gait. The different types of gait that can be noted include the festinant gait, wherein the patient has a stooped posture and walks in short steps. This type of gait is seen in patients with Parkinson's disease. On the other hand, a circumduction gait is seen in patients who have a pyramidal tract lesion. Here, the patient holds a limb stiff. The foot drags on the floor in a circumduction movement. The third type of gait is a cerebellar gait or a broad-based gait, wherein the patient may appear to be drunk. These types of gait invariably point us to a particular diagnosis. Before we go to examine the gait, we will talk about assessing the Romberg's test or the Romberg sign. This test is done by asking the patient to stand with his feet close together. This is done with the patient first with his eyes open and then with his eyes closed. If the patient demonstrates any swaying with his eyes open, this points to a cerebellar lesion. Whereas if the patient sways with his eyes closed, this points to a lesion in the dorsal column, which is also called sensory ataxia. Now I'm going to demonstrate the Romberg's test. Can you please stand up here? Can you keep your feet together? Can you keep your eyes closed? Okay, thank you. So let me summarize all that we have learned during the examination of the nervous system. We start off by examining the higher mental functions, followed by examination of the cranial nerves 1 to 12. Then the examination of the motor system, which is examined under the heads of bulk, tone, power, reflexes, coordination. This is followed by examination of the sensory system, and then we assess the gait. Remember, the diagnosis of a patient with the nervous system disease is invariably made by the end of history. The examination of the nervous system is a useful adjunct to help you come to a diagnosis.